Hi, everyone. Welcome to Within Summit. Wherever you are tuning in from, good morning, good afternoon. We're so excited to have you here. This afternoon, we are speaking with Dr. Jeffrey DeSarbo about the crucial role of the brain in eating disorders and the recovery process. Dr. Jeffrey DeSarbo is a physician and psychiatrist specializing in the treatment of eating disorders and is the founder and medical director of ED 180 Eating Disorder Treatment Programs in Long Island, New York. Dr. DeSarbo also maintains an active private practice, personally treating over 300 patients with eating disorders annually, and serves as a national and international consultant for select eating disorder cases worldwide. As a clinician, Dr. DeSarbo is both a psychopharmacologist and psychotherapist who incorporates psychodynamic CBT, ACT, FBT, and existential therapy into treatment plans. Dr. DeSarbo, we're so grateful to have you here today. Thank you so much for joining us.
Well, thank you very much. And thank you to Within for inviting me and everything. And I hope I can give some interesting information to everyone here. So I guess I'll just get started right away. So of course I'm dealing with a subject that's usually very complex and everything. I'm hoping my screen is coming up okay. I have some stuff. Is it okay, Cynthia?
Yep, everything looks great.
Okay. So mostly, again, my special interest is in the neuroscience and neurobiology of eating disorders, which is a slightly different take and perspective of treating eating disorders from the other modes of more traditional approaches and traditional therapies, traditional programs. But my special interest being in the neuroscience with the brain and the central nervous system, I believe, is really what an eating disorder is all about. Few people get access to this information. I know some people who are tuning in may have heard me give similar talks, but this one specifically is how it relates to recovery. So it's a complicated subject, but I hope to get it summarized and give a different perspective for people to look at what is an eating disorder, and most importantly, what is recovery truly. So, when we look at an eating disorder, people look at it from many different perspectives. It's really not about self-image. We know there's issues of food and control. There's a behavioral condition. A lot of behavior is specifically tied into the description of eating disorder patterns. There's a cognitive condition, which means how the brain thinks about an eating disorder and the self and self-judgment. It's an emotional condition. There's a lot of emotional fallout as one struggles with this. It's the word that I mostly think of is it causes an individual to go through significant distress. It is considered a psychiatric condition. That's why it's in the DSM-5 with its criteria that break up eating disorders into their specific types. And psychiatry is a specialty of medicine. So ultimately, when you think about an eating disorder, we are talking about a medical condition. And it really is that medical psychiatric component that makes it different than other types of psychiatric issues. So when we think about what is eating disorder recovery, it's in the field. It's always been hard for people to reach a consensus as how do we truly define recovery. Now, the one thing I'm going to say here that some people don't necessarily have this viewpoint, but it is that when someone asks me, is recovery, full recovery, always possible, or is it possible at all? As opposed to people who sometimes say, well, you're always going to have parts of your eating disorder. It's always going to be sticking with you. My thing is I have experience, and I always say I could bring about, dozens, if not hundreds of people who would be able to say, I really don't have my eating disorder anymore. It's not these all intrusive thoughts. I cope well with food. I think about and I worry about other things in life, and they don't worry about things like food and body image as much as any other individual who even doesn't have a eating disorder kind of contends with. But when we look and people try to define what's recovery, it's looked at from different perspectives. There's the criteria in the DSM-5, which defines what an eating disorder is and codes it. This is what insurance companies often look at. And so if you're no longer meeting every criteria of an eating disorder, they say, well, the person's in a partial recovery, or the person's in recovery, which really we know isn't true. The people who work in the field know that simply by going by a DSM definition is not truly represent what recovery is. There's the physical parameters. Sometimes people can say, well, their weight stabilized, or their medical labs are fine, their EKG's fine. Physically, they're stable, so they're in recovery. And again, that's not truly what it is. There's the behavioral parameters. Well, they're eating their 3 meals in 2 sacks, or they stop their binging, they stop their purging activities. Therefore, they're in recovery. And again, that's not really what defines recovery. There's the cognitive parameters. It goes back to the thinking. The thinking is not as distorted with their fears and fears of judgment, fears of foods, fears of weight gain. But what we're really going to focus on here is defining recovery from a neurobiological perspective. And whether it's bulimia, anorexia nervosa, or binge eating disorder, there's all these neurobiological correlates that kind of cause that distress I mentioned in the beginning. And it's only when the brain kind of restores itself to a baseline or beyond that one can kind of have the actual subjective experience of feeling recovered. So what is recovery that we're going to be looking at? Well, in scientific terms, it's a restoration to baseline of the neurobiological processes that result in stabilized brain and body function and mental function processing. And to kind of achieve this is where we're trying to get all the parts of the team in a cohesive fashion working with psychotherapy, nutritional rehabilitation, medical stabilization, psychiatric stabilization, to kind of work together to bring about changes that are both cognitive, physical, behavioral. But ultimately what's happening is by all of these different methods, we're working on the brain and the central nervous system, trying to restore that to a baseline. So this is one thing here that if people haven't heard me speak, this is one of the key measuring factors I use. This question right here to see how well is a person doing, where are they in their current state of an eating disorder, and where are they in their recovery phase. So I'll always want to know what percentage, this is what I ask my patients, what percentage of your free thoughts when you're not actively doing something else do you spend thinking about, worrying about food, weight, body image, calories, exercise, body checking, purging, restricting. And most people in their acute stage will say, when it's at its worst, 90%, 100%, all of my free thoughts are thinking about, worrying about, fearing these things. And that's where the true distress comes in. The other half of that terrible thought process that causes distress is one's own self-evaluation, feeling they're never good enough, they're not worth it, they're bad people in general. And so I always say, if somebody walks into my office and I ask them, what percentage of your free thoughts do you spend? And they say 80, 90%, even though they can be eating 3 meals a day, say they don't have any behaviors at all, they can be quote unquote a normal weight. If that percentage of thoughts thinking about, worrying about these specific items here, that's what a true nature of an eating disorder is. So again, it's not physical, it's not even behavioral, because this is where the distress comes in and it makes it difficult to live life. So in neurobiological terms, we see with an eating disorder in the studies and the research that's been done mostly through neuroimaging like fMRI and CAT scans and other types of PET scans and neuroimaging studies, that with eating disorders, there's studies that show that there's a loss of brain mass in certain regions and sometimes in different regions, depending on what the type of eating disorder. There's changes in the brain's anatomy, its actual structural shape and form, changes in brain chemistry, the neurohormones, the neurotransmitters like serotonin, dopamine, and many others. There's changes in how the blood flows in a brain that causes a lot of the ways a person thinks or perceives things. And all of these changes in how the brain is functioning leads to these changes in the thought and the cognitive processing when one's in it. So I'm just going to be laying a foundation here, kind of like showing you some of the studies without getting into detail, because that would take forever. And keep in mind that what I'm presenting here is a tiny, tiny fraction of the research and studies out there that show all these specific changes that take place in the brain and the central nervous system in people that have eating disorders and the specific subtypes of eating disorders that they have. So I always think like, well, if we want to first look at, well, is an eating disorder truly an organic process? Is it really something about the body, or is it just in the mind? Is it just in thoughts and psychology? Well, some studies that support is truly an organic process have shown that people have had spontaneous changes in their eating patterns that qualify for eating disorder diagnosis due to things like having brain lesions, strokes, seizures, tumors. And they would in some of these cases, they spontaneously developed an eating disorder. And in other cases, they'd had an eating disorder and spontaneously it resolved itself with some of these types of brain lesions, even without intensive treatment. But, they can have this traumatic lesion in the brain and the eating disorder kind of like goes away, essentially. Now, this isn't a common process. This isn't what we look for in treatment, but it gives that evidence that there definitely is a biological organic process going on. Now, what's important to understand is the eating disorder itself, as a neurobiological process, there's a lot of changes in some of the studies I'll show you that take place within the brain. And I mean, there are multiple changes and it's different for each individual. And when the brain changes, it can affect all the other body systems like the gastrointestinal system, the reproductive system, pulmonary, and the renal system. And when this happens, you get a lot of the medical complications that can come up in the treatment process. Now, in return, sometimes when someone is having a medical condition associated with an eating disorder, let's say with their cardiovascular system, there are signals that are sent back to the brain from the cardiovascular system, from the immune system that regulate how the brain function and it works. So the brain is tied in with all the other body systems. So when you get changes to the brain, it can affect the other body systems. Or if you get changes with the body systems, it can affect how the brain's functioning. And this is a back and forth process that people who are working with to get somebody into a recovery phase has to deal with. So when we look at the different things like the endocrine system and hormones, people often forget even adipose tissue, fat tissue itself is considered an endocrine organ. It's responsible for kind of like producing and manufacturing all these biological peptides, which act to kind of regulate the body's hormone systems. So you can imagine when somebody's dealing with, let's say, a case of severe anorexia nervosa and their body's fat content is minimal, it's going to have tremendous fallout from an endocrine point of view. So again, that's where we would start worrying about things like osteopenia, osteoporosis, menstrual cycles are disturbed, fertility, reproductivity, and other neurohormones that also regulate mood. So even adipose tissue itself is an organ that in certain types of eating disorders like anorexia nervosa can be severely affected. But we often, especially the person who's struggling with an eating disorder is looking at adipose tissue as fat, which is bad, and is trying to eliminate it. It's just as important as trying to eliminate other endocrine organs. So, and I just want to follow up with that. When we look at these adipokines and lipokines, they play an important role from a neurological perspective. So when we look at things like leptin, it's important for cells to divide. It protects brain regions like the hippocampus, which is important to memory and moods, and a lot of these different neuroprotective roles here, as you can see, with each of these multiple different types of neuroendocrine substances are really involved in the central nervous system's cellular reproduction, cellular system kind of falling apart, and brain volumes being reduced. So they play very important roles. So when we mess with an eating, like the adipose tissue with an eating disorder like anorexia, we're messing with the organ, and we're messing with all these protective factors that then lead to more complications biologically and medically with an individual who's going through it. The one thing that's, again, biologically, when we're speaking about this in recovery is, there's a lot of information out there on genetics, and other people may present, but I do like to just review that a lot of the work, especially by Cynthia Bullock and colleagues, have been involved with genetics and continues to be with genetics and epigenetics. But if somebody in my office says, why do I have an eating disorder? Okay. On average, things like anorexia and bulimia, about 60% of the onset can usually be attributed to just genetic factors. So people can be prone to it. And so even if somebody isn't necessarily exposed to the impacts of media and the need to be thin in society, or you're going to be alone the rest of your life and things like that, if you're prone to it, you're kind of set up to, under the right circumstances, develop an eating disorder. And that falls into that concept of epigenetics. So things like just trauma, mood, the psychological states, people who have any sort of stressors, be it medical states, diseases, interpersonal interactions, things that happen during personal development as a child, of course, diet and exercise. If you're prone to that eating disorder, it can be triggered. That can be the epigenetics. It kind of turns on the genes that make you kind of express the type of eating disorder you may be prone to. Again, illicit drugs, cultural expectations, the need to feel perfect, issues with struggling with personal or sexual identity issues. And again, we go back to just what sets it in motion is that concept of having the genetics that kind of predispose you. So if we're trying to define an eating disorder in neurobiological terms, not just what a DSM-5 says, essentially an eating disorder is a neurobiologically driven process which has these psychological and these medical consequences. And again, it's not a choice, because you have to have that biology and that predisposition. You can't really create an eating disorder if you don't have that set up. You can develop disordered eating, but not an eating disorder per se. So I always like to show this, because when we're working and somebody doesn't have an eating disorder, we want the central nervous system firing off in a very robust manner. All the cells are communicating themselves. But when you have eating disorders such as anorexia nervosa, you get this like hypometabolism in the brain, and depending on which regions it's affecting, that can affect how somebody thinks, processes information, sees themselves when they look in the mirrors, thoughts and fears about self-judgment, fears of judgment of others. And recovery is getting that central nervous system to fire off back in a healthy manner. And like I said, it can be different for different people what regions this affects. That's why one of the regions that's usually not affected is things like intelligence and academic performance. So that's why many eating disorders can be missed, because, well, they're getting straight A's. I didn't think anything was wrong. Meanwhile, upstairs in the head, everything else is going haywire. It's not functioning the way it should be. Now, when we're looking at the eating disorder and what happens during it, there's lots of studies, and these are some with anorexia nervosa. You actually lose cellular volume in the outer cortex. That's like your gray matter. And it can be, again, in different regions and different people. But you can see in this slide right here, you can have, anywhere from kind of like 4 to 6% adults, and in children, close to 8% of a gray matter volume loss, which is, we're talking about hundreds of millions of brain cells. We all have, 100, 125 billion brain cells. So when you're losing like 5% of that, we're talking massive amounts of cellular connections. And that's why you get that slowing, you get those kind of short circuits and hiccups in the way one thinks. It's like I said, they can be a straight A student, but I always say if you put a hamburger in front of somebody, despite getting straight A's in physics and chemistry, the cognitive perception is if I eat that hamburger, I'm going to gain 5 pounds, which is, scientifically not possible. But parts of the brain that are supposed to connect with each other and kind of reality check and test their thinking processes get disturbed when somebody is dealing with an eating disorder, especially when it comes to things like this in anorexia nervosa. And again, that white matter volume loss is really, it's what you see in this picture in all those different colors, all these tracks that connects certain regions of the brains to other regions of the brains. And like I was talking about the hippocampus before, which is so important to sleep and memory and trauma. Like sometimes when people have trauma, they can lose 6 to 8% of the brain volume in this hippocampus. This isn't located in a region of the brain called the limbic system, which is kind of your emotional brain. And so the more severe eating disorders get, you tend to find more cellular volume loss or lower function and activity in these regions. In some regions, like an amygdala, you get disturbances where there's hyperfunctioning that's going on. And the amygdala is that fear center. So people really start to worry more about the eating disorder and what food and everything has as a meaning towards it. Certain regions too, when it comes to behavior such as restricting or this need to be thin with anorexia nervosa, like this study in particular here shows how there's decreased gray matter loss that's in some of these regions, especially in that parietal center of the brain, that there's a direct correlation. So the more volume loss that takes place in regions such as the parietal or the anterior cingulate cortex starts to occur, the stronger the drive becomes to lose weight. That's why, in the recovery process, when let's say somebody with anorexia is working on restoring weight, they get up to a certain number and they start to struggle because they're giving the substrates to kind of build those connections again in the brain and other parts of the central nervous system. But the regions of the brain that struggle with body image may not quite be caught up. It takes time for someone to learn to become able to tolerate changes in their weight or body image. And so there's this time where it's like, I think I just overshot my mark. Let me just lose 2 pounds. Excuse me. Now, if somebody starts thinking this way, if they lose 2 pounds, they think that won't be a big deal. Now, if they're prone to losing weight in these sections of the brain, then it can start to spiral because of that direct correlation. The more weight that's lost, the stronger that drive. It's a biological drive for thinness becomes. So it sometimes, people don't understand that concept from a biological point of view. It's more or less, well, they lost some weight, they liked it, they want some more. It's more than that. It's actually a drive that starts to take place. And that's why when people are working in recovery and they're in a program, you want to help them not just get to that target area, but they have to maintain that, usually for at least a year. You can't, every time there's a small setback, it has to be addressed kind of aggressively and right away so that it doesn't spiral out of control. Excuse me. So usually when somebody's in my office, if they've lost, let's say they come in, I don't usually need to see a number on a scale. I can tell based on changes in their cognitive processing and thought processing from their last session, if they're restoring weight or if they're losing weight, simply because of the logic that takes place sometimes in that cognitive processing or the emotionality that's present with it. I'm sorry, I'm joking. So I like to explain to my patients too that, if you think you're going to lose even a small amount of weight, like 2 pounds, that can, again, result in hundreds of thousands or millions of cellular connections in the brain. And we just don't know where that's going to kind of go faulty. Let me go back. So this again talks about how at different stages you get decreases. I think I actually had this slide here. The cortical thickness, again, and by that means the thickness of kind of the cortex of the brain, it's related to a person's age and duration of how long they've had that eating disorder. That's why, depending on when a person enters treatment, if someone enters treatment for the first time after 10 years of dealing and struggling with an eating disorder, biologically, it's a lot more work to get them back to a baseline. And one of the things, again, with that fear of gaining weight, is you get a lot of disturbances and associations and a dysfunction that takes place in areas like that little pink area there in the amygdala. So that's, again, where, you put a hamburger in front of somebody or a food they're not used to, and they get this terrible emotional dysregulation because that fear center is kind of going completely out of control. And it shows like there's a lower amygdala volume that's associated with that increase of body image distress and phobias and mood changes. This kind of, it just reinforces again that body dissatisfaction is kind of found in these regions of the brain, that there's cortical volume loss. And again, whenever there's volume loss, there's usually an associated decrease in activity, like the brain's not functioning well and kind of in its high gears in these activities, and therefore it's not communicating with other regions of the brain. And a brain is like a fingerprint. So one person struggling with an eating disorder may have different fallout from one region of the brain to the next than another person. Even if it's like restrictive type of anorexia, it can still be a different type of brain that's kind of reacting to its deficiencies. Now, sometimes there's findings such as with bulimia and binge eating disorder that there's actually increased gray matter. And that's, here you see it's in the orbital frontal cortex and the ventral striatum. These are areas that are important to processing, especially when it comes to reward and brain kind of like almost like addicting patterns. So again, with binge eating disorder, someone feels that loss of sense of control. And again, it's not just a psychological perspective, but we actually have these anatomical changes such as increased gray matter that's taking place in regions such as the orbital frontal cortex and ventral striatum. And then when we're looking at certain types of behaviors, there's plenty of studies out there that show, like, the people who are bullied, people who suffer trauma. It's a predictor of eating disorder psychopathology, and there's changes in certain regions of the brains that cause an underdevelopment, which seem to correlate with maybe it's that epigenetics of setting somebody up to turn on those genes that develop that full-blown eating disorder because of these types of social interactions. And social media and eating disorders, this could be a full conference of itself, if you ask me. And it's one of the biggest obstacles. Those who are suffering with an eating disorder, parents who have children or loved ones who are suffering, and therapists have, is we're living in this world where everybody is way addicted to their cell phones and their likes and their Instagrams. And it's that perception that, everyone else's life is so much better than my own. And I can go online, I can compare myself to different bodies. And no matter how much one tries to block or limit exposure to even eating disorder posts, such as on TikTok, it can't be done. Their algorithms are too complicated that they're going to keep getting this information, which ultimately is, when you say it's affecting an individual's psyche, it's affecting an individual's brain. And there are lots of studies that show changes in certain regions. Right here, it's a nucleus accumbens. Again, it's associated with the brain's reward systems. And it leads to a desperation in kind of how one is trying to manage their eating disorder. And like I said, everybody has a different route. So when one area of an eating disorder is affected, let's say that parietal lobe, it can affect different areas of the brain. And, this isn't a lecture to describe what every part of the brain does, but areas like the anterior cingulate cortex and the insula, like the anterior cingulate cortex, I heard my best description is it's a region of the brain that regulates where heated emotions meets cool rationality. And I think as treatment providers, we can recognize this. And as family members, they can recognize this change kind of like in a personality of people who are struggling with an eating disorder. In that a person just isn't themselves. So you can imagine that heated emotionality becomes way escalated, okay? And that the cool calming effects is harder for one to kind of control. And as a psychiatrist at times, people may come to me and say, hey, can we give some medications or something to help somebody calm down, to help them, reduce their anxiety and panic? And often what I'm trying to deal with is decreased changes in the central nervous system. So I'm trying to fight a biological process that's being caused by the eating disorder itself. Same thing with therapists. I always say, if you can imagine somebody who's, especially when they're at some of their most acute and serious levels struggling with an eating disorder, and you're trying to do therapy where most of their thoughts cannot stay focused on therapy itself. The process is so difficult. It has to be kept simple in the beginning. And it takes a while. And it's not just that one region, if it can affect your fear centers. And when you have that cool rationale is lost, you start to panic and you have that fear much more easily. And that's going to escalate the eating disorder. It's going to cause problems in relationships. The person's going to feel worse about themselves, and that judgment gets bad. And that's why I always say, like, even when we're talking about distorted body image, a person looks in the mirror, they're not just seeing the body itself, they're seeing the person that's with it, so they're actually seeing inside themselves how they feel about themselves. So, you look in the mirror and you say, I hate myself. It's not just usually the image, this isn't some deep thought that one's realizing when they're thinking that way, but it is something that contributes to that emotional dysregulation, ties in and affects that other region of the brain, which causes distortions in body image. And if you want to understand something like how does that happen, like this is a study I always like talking about, because it shows like there are changes that take place to the temporal lobes of the brain especially, and there's other regions too that are involved, but that cause one to have this distorted body image. So a person looks in the mirror, and as I had a patient once say, I'm Harry the hippo, and they looked in the mirror, and that's what they saw. A lot of times family members with good intentions or providers who don't understand may say things, but you don't, you're beautiful, you look great, you look fine, and that's not what they're seeing. The reality to the individual of what they see is caused by anatomical changes and physiological changes that are taking place within the brain that are associated with the eating disorder. So they're being told they look fine. They see something different. They don't trust. They lose trust and faith, and trust is a big issue, of course, therapeutically working with people. So I'm usually, advising people if a loved one says, I'm looking huge when they're dealing with, let's say, anorexia, you refer more to their feelings. Like, are you having a tough day? Is it, have you been extra stressed? Rather than trying to respond with any comment related to physical appearance. Of course, you get changes in blood flow, you get changes in all the neuroreceptors as well. And I always just show this slide because it's not a simple problem. It isn't like, let's just check serotonin levels and see what's going on, or dopamine levels. There's some of the more popular ones are things like all these changes in studies that have been found with different types of mutations or differences in the receptors of serotonin genes, because you don't just have one serotonin gene, you have multiple types of serotonin genes or multiple types of dopamine. BDNF I'll talk about, brain-derived neurotropic factor. And again, there's other types of neurohormones, neuropeptides, opiate, the body's own opiate receptors, the body's own endocannabinoid receptors. There's all these different ones. And I list all of these because each of these has multiple studies that show differences in the neurotransmitter and receptor systems in people with eating disorders, and even more. Okay, so trying to find a simple answer is not easy. And I always caution people when listening to anything in the media or something, and if somebody's talking about tumor necrosis factor receptors related to this type of eating disorder behavior and binge eating or bulimia, and they want to say, they think they found it. It's not. It's a very complicated process, and everything also has a cascading effect. So kind of like the different regions of the brain, if one of these affected, it can affect multiple different types of transmitters and receptors. So one of the big ones that's important in stress, it's not just with eating disorders, but anyone who has post-traumatic stress, severe anxiety, if you're living with untreated depression, anxiety, the body normally produces this protein called brain-derived neurotropic factor. And it's very protective of how one nerve cell kind of communicates with the next. It's through those little fingers of dendrites. And when people are under stress and with eating disorders, people start to lose brain-derived neurotropic factor. The body stops producing its own protective factors. If we ever had a medication that reduced one's brain-derived neurotropic factor, nobody would take it, But we sometimes that's why I say, like, there's side effects to no treatment, whether it's no treatment with an eating disorder or there's no treatment with anxiety or depression. The body's systems itself, what it's supposed to do, the good things, stops making them. And with an eating disorder, sometimes lacks the capacity to make them because of nutritional status. Really what this study is talking about is that with weight restoration, levels of brain-derived neurotropic factor kind of start to return to normal. Okay, so we start to, during the recovery process, as one keeps getting better and better, we're rebuilding the brain and how it communicates with each other. We're putting in protection for that to stay there. That's why, like I said, you have to stick with recovery long term so that it can kind of like, let the cement dry on these new healthy patterns of way of functioning and thinking. That goes to, like, again, how does sometimes when someone struggles with an eating disorder, the brain, the actual structure and shape of the brain starts to change. And the more serious in this study, what they were talking about was the more serious with binge eating and purging, frequency, severity, and duration of illness, the more changes we see that take place in the brain anatomically and in different regions for different people. And as I mentioned, in the last thing, it says brain regions compromise both reward and cognitive control circuits. That's, again, a lot of that stuff is in the frontal lobe and in certain parts of the limbic system and emotional system that get affected, where the actual physiological shape and anatomy of the brain is starting to change. And again, it is actually through the treatment with both psychotherapy, nutrition, sometimes medications, that what the goal is to kind of restore the brain back into a healthy physiological functioning, and the anatomical structures seem to come back in most cases with everything that has been changing during the course of an eating disorder. Now, one of the things that's when you think about, well, we're doing treatment, let's do nutritionists, let's do psychotherapy, let's see the psychiatrist, and things still aren't going quite as well, or at least not progressing at the rate that we hoped they would. And you're trying to think, well, what am I missing here? Well, some things are so hard to actually know and understand. One of the things about this study that I did find interesting was the vagus nerve, which you can see here, comes right out of the brain. It's considered one of the brain's central nerves. It kind of has misfirings at time, and that long nerve that comes from the brainstem, it's called a cranial nerve. It innervates different parts. It goes to a lot of sections in the gastrointestinal tract. It innervates the heart in significant manners that can affect arrhythmias. And again, it's associated with how it fires with things like mood and depression. Well, in this study, they found that there were people who had an irregular firing with this nerve, and it correlated kind of directly to their intensity and their frequency of binging and purging. And when they treated it with a medication to kind of normalize the firing of the vagus nerve, about 2/3 of the people had a significant remission in their bulimia symptoms of binging and purging. Now, sometimes, I'm presenting and people say, well, why don't we use this medication more often? Well, because this nerve does innervate the heart and some other parts as well, the medication actually can have a side effect of potentially causing arrhythmias. So the risk reward in cases like this are not worth the medical intervention. And although there have been some cases that I've worked with where there has been that significant reduction in behaviors of binging and purging when using a medication that can regulate this vagus nerve. There have also been, there's an implant device that regulates the vagus nerve too, which was originally created for mood and depressions, which significantly helps people with their mood and depressions. And the studies, even with eating disorders, although they're very small and limited, have shown positive responses to reducing bulimic tendencies. So I always like to present this to show, like, yeah, we can talk about changes in the brain, etc. But here's a classic example how one of the main nerves of the body, the cranial nerve, is misfiring and leads to all of these physical and behavioral kind of presentations. And no matter how much therapy one does or nutritionally changes things, if the vagus nerve is still misfiring, and that's potentially one of the cause, somebody can be getting the greatest therapy and nutritional guidance in the world, but still struggle with these urges to binge and purge. Which goes to kind of like a lot of people want to know, someone with an eating disorder, are these changes related to the development of the eating disorder, or are there pre-existing types of conditions, circuits, changes in neuroreceptors that are kind of there and contribute and cause the eating disorder? And it seems to be, well, most of them are reversible. So they seem to be what's called state related, in that if you treat the eating disorder, you get a lot of corrections of any dysfunctions that are taking place. However, there are some studies that show certain regions of the brain seem to make people more prone to an eating disorder, kind of that medical condition being the epigenetics that can cause the onset of the full presentation of an eating disorder because of a trait related to their biology that is kind of there before anything gets started. We just took time. Okay. Again, this is kind of like there's that resting state hypoconnectivity. If you remember the white tracks where one brain is connecting to different parts, and again, a lot again with binge eating disorder in that frontal area, the nucleus accumbens again, that they're just not functioning and kind of like biologically allows the individual to regulate their emotions and how that ties into their food and eating patterns. Same thing here, neural activations, certain regions that this just shows you different areas of the brain related to body shape, anxiety, and in adolescence, okay? And sometimes again, adolescent brains, they're still forming. So, the one thing you wanna always do is aggressively kind of like deal with the eating disorder when it's recognized early on. Now, later in life, it's a total different process. You can use cognitive therapy, whereas with adolescents, you're going to use behavioral therapy because their cognitive regions aren't as developed. But so when we're looking at some of these regions here, they start to fall into the limbic system, that emotional brain. That's why a lot of treatment for eating disorder types of thought process and behaviors is handled more behaviorally with an adolescent or child than with an adult. So essentially here, effective treatment to like kind of work on some of these dysfunctions biologically that are taking place with the brain and central nervous system. Effective treatment is to change the brain, which improves the neurotransmission and the functioning of the neural networks and its communication. And those changes in a person's mindset takes place on a molecular and cellular level. So even when you're saying, oh, look, they're happier, they're more emotionally in control, they have some calm, cool rationality now, that's because of what's taking place on a molecular level in the central nervous system. And again, achieved through psychotherapy, nutrition, medical interventions for stabilization. So again, there's just some things here. The psychotherapy, this is just evidence. These are some of the studies. Again, tiny little fraction. It shows how psychotherapy changes the brain and what regions it seems to take place versus things like medication. To keep things simple for now, it's often heard that medications with therapy work better than either one alone. Okay. Now, when it comes to certain types of moods like depressions and everything, psychotherapy, it's considered a top-down approach. It tends to work on the outside cortical areas of the brain, which then kind of improve going down into deeper into the brain, the limbic system. Whereas medications seem to work what's called bottom up. It tends to work deeper in the brain on neurotransmitters and everything in the limbic system, which then flows to the outer cortex, which is where you process your thoughts and your cognitive decision making. So it's interesting because like there are studies with anxiety and OCD that say like, well, but medication and psychotherapy seem to work in both similar manners. But what's important that I'm trying to get across here is psychotherapy itself is a key component to changing the brain. And these are just more studies that go back even further where they started looking at this.
Dr. DeSarbo, I just wanted to give you a heads up. We have about 15 minutes.
Okay, thank you. So of course, a lot of all of this is really brought about because of the advent of brain imaging. And I think, I always encourage, whether you're a layperson or a clinical professional, that you always stay on top of trying to understand what's going on with the different parts of the brain. As it, I think in treatment, for myself, it lets me think about where in someone's head do I need to kind of like focus treatment or target something, even if it comes to selecting a med. But I think it helps the therapist, the family, and the patient if like, let's say you understand some simple terms, like if it's the ACC, that anterior cingulate cortex, and it's someone says my moods are all over the place, I can't keep myself calm and cool, and and you say, well, that can be related to changes that take place in these regions, such as the anterior cingulate cortex. The reason you need treatment, the reason what we're trying to do is restore the functioning of that region, and you will start to feel calmer. You will start to feel less impulsively emotional over certain types of thoughts and decisions that you make. Even things like certain traits, such as perfectionism, go back to genetics. And in this study, it shows they feel 30 to 42% of the onset of perfectionism is related to genetic factors. And if somebody is thinking, if I'm perfect, then something. It would usually say, if I'm perfect, it usually boils down to, if I'm perfect, people like me, I'll be loved the rest of my life, I won't have to ever be alone. But perfectionism is flaw, and you use things like therapy to help people understand, well, if I'm perfect, I mean, like, ask yourself, do you know perfect people? How do they make you feel about yourself? Usually if somebody is perfect and they think, well, people are going to like me more, the truth is they're usually reminding people in today's world what they're not. So now that's trying to work through in a cognitive process. If a person starts to understand, yeah, maybe I don't need to pee, or maybe I shouldn't be perfect, then what's taking place is at that molecular cellular level, and new connections that are taking place with different regions of the brain. And I just find this is an interesting study. It's an MRI scan of somebody who's presented with political opinions that are different or opposite to their own stance. And it shows that the high levels of the cortex that provide rational thought get less blood flow than other areas that are going back to concern their beliefs. So someone strongly has an idea, a belief, a conviction, and they're presented with an idea that's opposite, really their brain shuts down. They're not listening to it. Okay. And of course, I think we all think, well, that's going on all over the place in the world today. And it is, and it's all a brain function. The thing is, when you think about what we do in treatment, what happens to a high functioning area of the cortex when a person with an eating disorder is presented with rational recovery thoughts that conflict with their eating disorder ideology? So it's like, no, you have to eat, you need to restore weight, then you'll feel better. That their brain begins to shut down because that's not how they're, as we often say in the field, their ed voice is processing this information. So again, because another difficult concept in treatment for recovery. Medications, okay, vitamin F is often what we say. It usually is nutritional and it's food. But when you go into nutrition, and people say, well, we need to check vitamin levels or we need to get a variety of foods. Again, from a neurobiological point, let's look at some of this. If you look at deficiencies, zinc, for instance, which is commonly deficient, it's a neuromodulator, okay, especially in certain regions of the brains, which means without it's kind of coordinating the functioning, the proper functioning in the hippocampus, the cerebellum, the hypothalamus, which communicates with all parts of the brain. Vitamin D, okay, it's for neurotransmitter synthesis or manufacturing and nerve growth. Okay, so when you don't have enough vitamin D, there's a lot of fallout from it. Copper, cellular respiration, neurotransmitter biosynthesis, connective tissue strength. Sometimes understanding from, again, the neurobiological perspective, why do we need this variety of foods? Why do we need to not be deficient in certain vitamins and minerals? And again, this is just a small list of them. And don't forget that cascading effect. If you're low in copper or zinc, it can affect a lot of other neuro connections, manufacturing processes, cellular death, RNA formation. So these micronutrients, from a nutritional point of view, a nutritionist really is working also on a neuromolecular level to help restore a patient. It isn't just, I need your weight to go from X to Y and Z. It's, I'm trying to restore what the brain needs so it functions best. Going back to this, it's kind of like I covered this, but it's you don't want to go into that hypometabolism. And there's a normalization, for instance, of how the brain functions with weight restoration, because of glucose. The brain and the central nervous system runs almost exclusively on carbohydrates and glucose. And when one is restricting these types of macronutrients, you're going to have this hypometabolism in the brain taking place. Now, when it comes to medications, and this isn't about it, there's very little we can do. You got Vyvanse, which is FDA indicated for binge eating disorder, Prozac for bulimia nervosa. However, what we try to do is we use medications to see at times, what can we do to help a person's cognitive processing? How can we help reduce some anxiety? It's hard to, you can't really treat a depression caused by the eating disorder as its source and expect the same results of an antidepressant as you can if you're treating major depressive disorder in someone without an eating disorder, because it's being caused by both a biological factor and the emotional fallout from just having the condition. And a lot of meds like the Vyvanse, there's overlapping circuits that you find in ADHD and binge eating. And so that's why it seems like, well, why does a med for ADHD help somebody with binge eating disorder? And it's because the circuits kind of overlap. Antidepressants, they often decrease the body's production of cortisol, which is a neurotoxic hormone. Again, something the body will produce all on its own under periods of stress and with eating disorders. Transcranial magnetic stimulation is changing the blood flow in the prefrontal cortex. It's a biological treatment. Neurofeedback, more biological treatments, trying to help someone learn how to kind of regulate their thought processes. I always say the difference between medication and meditation is just one letter. And I'm a strong supporter of mindfulness. You get cellular growth by learning mindfulness and meditation, although it takes a long time, but people can start with simple mindful exercises. Recovery here is, in the study, anorexia nervosa, 31% of people recovered at a 9-year follow-up. I always show like 20 to 25 years, it's doubled essentially. this for me is an argument against, well, palliative care automatically, even at 9 years of struggling with an eating disorder, let's give up, because people still continue to recover. Bulimia nervosa, it looks like there's no recovery past 9 years, but that's not really what it is. Some of the people in the 20-year follow-up have recovered while others had relapsed. So the recovery rate overall is kind of pretty high. And again, when you recover and you change the central nervous system, you're changing, again, all of these body systems: endocrine, gastro, pulmonary, reproductive. So in scientific terms, what recovery is, it's a restoration to baseline of the neurobiological processes in the brain and the central nervous system that result in a stabilized brain and body function, and thus kind of a better mental functioning process. So I have a couple minutes for questions. I thank everybody for learning here. If anybody needs to reach me or anything, there's some ways right there. On YouTube, I do have a 15-part a neuro series on eating disorders. It kind of talks a little bit more in depth with some of these types of topics I've covered today. But are there any questions, Cynthia?
Thank you so much, Dr. DeSarbo. We do have a couple of questions. The first one is from Lacey, and she wants to know, is there a direct correlation between high or low amounts of adipose tissue and endocrine system upset?
Yes, usually that most definitely there is. And it's very, that's why some of the first things when somebody starts to slide into anorexia is you start with the lab work and with the neurohormones. Everything is getting thrown off, and there's only usually a subset of neurohormones that are looked at with on most physicians lab works. They look at the like the reproductive hormones, your thyroid hormones, and a lot of those are, again, just purely nutritionally happening, but when it's combined with that loss of adipose tissue that produces all of those adipokines and lipokines, you're going to get serious fallout. It's just a matter of, why does one person have this endocrine fallout and another person has this one? But that's why, you get that all kinds of both internal physiological changes as well as external faces, like the soft hair on the face and things like that. That's all hormone related.
Beth would like to know, so you had discussed copper and zinc and various other nutrients, and Beth is a dietitian and was wondering if you could explain how an eating disorder multivitamin is not enough for recovery.
Right. Well, they're usually not enough, and it's hard to know exactly what to give, mostly for a few reasons. So one of the major systems that's affected is that a person's gastro system, their gut. So malabsorption takes place, for multiple reasons. So usually taking a vitamin, even if they are taking a liquid vitamin, which sometimes is a little bit better, it's just not absorbed. The other thing is the deficiencies can be, like most of these multivitamins, they're usually it's supplements to what people are eating, not replacements. And I think sometimes a person struggling with an eating disorder or any kind of nutritional deficiency is thinking, oh, well, I take a supplement. But you're not. What are you supplementing with? If you eat nothing, you're not supplementing. You're counting on that as your primary source, and the vitamins aren't made for that. The other thing is, it's like I said, there's a cascade, and there's other types of proteins and other cofactors that are needed. So when somebody takes, let's say, supplements of vitamin D or copper or zinc, as opposed to getting it from a food source, they're not getting the coenzymes and cofactors they often need to make those vitamins work. So that's why, again, vitamin F, the food itself, is the main, vitamin that's needed. But you still try your best if you find these types of deficiencies, whether somebody is following a mealing plan or not, you still try your best to regulate, to minimize any disruptions in the central nervous system.
I know we only have a minute left. We do have a couple more
Okay.
questions. Sorry. We have one from Ali who says, could you explain again what you mentioned earlier about the importance of maintaining weight restoration for at least a year before seeing changes in recovery?
Sure. And if anyone has questions I'm not getting to, my email's there. And if you just give me a day or two, I'll get back to you with your questions or anything you need, Dr. DeSarbo at Gmail. So if I didn't get to your questions, you want to email me your questions, I'll respond to you. What I'm saying is, so the eating disorder, the brain takes about 180 days for it to kind of reestablish new connections and pathways. So you need to kind of maintain the process of recovery so that it starts to, if you think about constructing roads, it's kind of plowing these new roads. They're all dirt paths and everything. It's going to be this complex structure of highways and roads. The reason I say, so in the first 6 months, you get this foundation laid. The next 6 months and beyond is where the roads are completed, the concrete's laid, okay? It's kind of broken in. So that's why you need that 1 year. Like I said, if everything goes perfectly correct in the treatment of an eating disorder, a year minimum before someone might start to say, I'm feeling like I'm getting into recovery, okay? Up until that time, it's still under construction. Now, the longer you go, the more developed that network is in the brain and the more concrete it is, okay? So that's what I was kind of referring to. In fact, my center, ED 180, people always think it's 180 because it means, oh, you're turning this around. And the truth is, primarily what I'm saying is 180 is 6 months. So 180 days, because that's what you need to kind of build the foundation in the brain and central nervous system. And I always tell people, if in 6 months, doing the same thing in your treatment program is not getting you anywhere, you need to change that treatment plan, okay? It shouldn't be staying stagnant for 6 months. And again, I think that's looking at it from a medical point of view. So, but again, other questions, I'm more than happy, if somebody wants to send me an email, okay? And I do appreciate everybody who turned in to listen and has an interest in this area, because I think it's crucial. So.
Thank you all so much for attending today. Unfortunately, that's all the time we have. Dr. DeSarbo, we appreciate you so much being here with us at Within Summit, and we look forward to seeing everybody at the next session.
Okay, thank you to everybody, and Wendy and Mateo and Cynthia and everybody for everything. I appreciate it.
Thank you all.
Thanks.
Bye.